Right, good morning everybody. Welcome to our public board meeting. We have an apology for absence from Liz Sayre, who was with us last night looking really poorly, so I'm not surprised that she isn't here today. While I'm on the subject of apologies, we've got really quite a long agenda, so I'm going to give notice now that there may not be any time for questions from the public. We'll see how we go, but I say that right up front so that we no nasty surprises at the end. Declarations of interest. Does anybody need to declare anything? Excellent. Minutes of our April meeting. They're a true and fair record of everything we discussed. Very good. There's one item on the public action log that has been actioned, so that is complete. That's excellent. Is there anything arising that's not otherwise on the agenda that anybody wants to raise? Perfect. David, your report, sir.
Okay, thank you, Peter. I normally report on the performance report, but there's a fourth quarter's performance report, end of year report, which is the next item. So I'll not comment on that until the next item. The report today is really an update on work that is underway and progress, and I don't think it needs to detain us. Andrea might want to add a few words to this. Held a round table on the use of surveillance and the regulation of services, and there's a brief paragraph reporting on that, and there'll be a further proposal brought back to the board in July, which will take that work forward. Do you want to say anything, Andrea?
Yes, thank you, David. And I know that Peter was interested in following up on this one as well. Just to say that the roundtable, whilst what the origins of this was our desire to look at the information that we provided both for the public and for providers on the use of surveillance, which we did over 3 years ago, and we want to update that. Life has moved on considerably in those 3 years. We also wanted to kind of make sure that it wasn't just focused on adult social care, that it also wasn't just focused on the kind of pure narrow focus of cameras in care homes, which is kind of how it's been characterised. The summary of the event, I'm expecting to get a draft of that next week, and we will put that out on the website, which is one of your questions, Peter, as to whether we would make that available. And what our plan is to update that information for the public and providers, but more of a web resource, so a little bit like what we did for Equally Outstanding, in terms of looking at producing that information in a way that is much more accessible for people, much more widespread. There'll be work internally within CQC, making sure that we're linking up with work that Malta is leading on through the Technological Innovation Reference and Steering Group, and it'll obviously come to ET, but we're expecting to bring this back to the board in July.
So, just so I'm clear, and to save Mr. Hogarth asking the question if I allowed time for public questions, so when you say you're bringing it back to the board, that is what? The guidance?
The proposed resource that we would be wanting to put out into the public domain, yes.
Perfect, thank you. So see you in July, David, is the answer. Right, thank you.
I just want to draw the board's attention to the work which has gone on in relation to preparation for the General Data Protection Regulations, which come in on the 25th of May. We've had some previous discussion about this, but work is to hand throughout the organisation in relation to developing our response to the GDPR regulations, and we'll continue to pay attention to ensuring that we can discharge our responsibilities under that new responsibility. We've had no recent publications. That's mainly due to the local government election and the fact that we're in that pre-election period, previously known as PERDA. So we've not published any reports during that period. But we've got 2 reports coming up. Ted's been leading a piece of work on best practice in managing demand in emergency departments, which we're looking to publish is it next week, Ted?
Next Thursday.
Yeah, next Thursday. And then there's some work on in this series of publications on driving improvement and what we can learn from providers that have made improvements. And there's a publication coming out from the engagement team based on the learning from adult social care providers that have improved their ratings. So to keep up that theme, not just of where there's poor care, but what it is that works when there's successful care. But that's the report, Peter. Thanks.
Okay, everybody. Thanks, David. So on to the performance report then.
So if I keep Sorry. I'm not going to present the detail of this, but this is the 4th quarter, so this is the data that will inform our annual report that we'll place before Parliament in early July as part of our annual report and accounting. And as a summary, I think captures what we're reporting in this year for 17-18 is the continued progress that we've made across the organisation on a whole raft of performance issues, which are evidenced in both the narrative report and in the slide deck that follows. Also included here is the annual provider survey, which we need to do further analysis and further work on, but gives you, a board, a good sense of what the providers that we regulate think about the experience of being regulated by CQC. So this is important feedback. We also ask individual organisations that we've inspected to give feedback about that particular inspection, but this is a more general set of feedback through the annual provider survey. And then the last summary point is that there's several areas, several targets, and I think they're set out in paragraph 3, where our performance has not met the ambition that we've set, the target we've set with the key performance indicator, and what they are and what we're doing to address our performance in those areas is set out in paragraph 3 of the report. I think if I pause there, Peter, if there are any questions that colleagues have on either the slide deck or the narrative for performance highlights in paragraph 2 or under target performance, which is set out in paragraph 3, we'll come back to that, and then what I'll do is ask Kirsty to present the finance report in Chris Usher's absence.
Silence. Anybody want to? I've got a few things that I'm going to raise, but yeah, right, good. John, then Paul.
Not quite sure which slide number it is, but it's on turnover.
It's on some of the first ones.
Manage our resources, turnover. And there's a slide that's showing 4. It's just a query on whether the 24% in the red band is considered high or average, or I don't have a sense. And if so, you know, is the rationale underpinning that statistic understood?
I was coming in on the train and I read these and I looked at this one and I thought, this is not probably the answer you're looking for. What I'd rather do is, I thought exactly the same. I thought, what does avoidable or negative actually mean? So I need to ask Ruth, I'm afraid, just to explain that. So what we'll do is we'll come back to you and give you a written response, and perhaps in the next board meeting we'll update that. No. I should know the answer and I don't, I'm afraid. But I don't know what it means, John. I know we're getting better at doing exit interviews. I know we're getting better at asking people why they're leaving and what is behind that. it'd be dangerous for me to guess at what's in that, and I'd rather not do that and give you a proper answer at the next meeting.
And, sorry, and just briefly further on, there's a, so this is picky point, so again, apologies, but there's a slide on safeguarding. It says the majority of which, bracket 45%, were noted for future reviews, and last time I looked at the Brexit referendum, 45% was not a majority.
Thank you. I'm glad you're reading the slides, and you didn't get them until yesterday as well, did you?
Noted. Paul.
Apologies. Thanks, Andrew. A couple of, the first one was actually just on the things that we've hadn't felt out. I'm going back, Ted. I come back to you every time on this one, hospital reports, and just in terms of the progress we might be making on that. We had a long discussion in ACGC in April about the NAO report and the challenge of getting the timeliness of hospital reports up from the low levels that they were at in the past to the targets that we've got. I think it would be helpful to know, whether the actions that you're taking, you feel that we're getting there.
Thank you for that, Paul. We have discussed this before, and I think the context of this is we've introduced the next phase of inspections very effectively, as the performance report outlines. And I think there has been a great deal of work gone into that. I think the one aspect of it that stands out that we haven't got quite right is the report timeliness. And we designed the processing the processing of the reports in a way that would be much more reliably delivering on KPI, but that hasn't actually happened. The number of days that it takes reports to be produced has come down, but has not got within the target threshold for KPI. And so we have more to do, and I think at the moment my sense is very much that we've plateaued out at the best we can achieve using our traditional performance management approach. And so we've instituted a quality improvement project, and indeed a very strong focus of quality improvement involving the people at the front line actually delivering this on a day-to-day basis to drive up the performance. And that is a very strong focus going forward. I think, to answer your question, Paul, we need to see some real improvement in the metrics further. So we've plateaued, we need to improve. And I think until we see that fully demonstrated, I can't give you a totally confident view on this, but I think we are doing all we can to bring that reporting timeliness down.
The information is really helpful as always. One of the most helpful bits about it, I think, is the way that certain elements, certain graphs fit together. If you have got time to sort of try and sort of cross-relate them, I just wonder whether in the future we might be able to do more of that. I mean, there's a slight danger, I think. I mean, it's very good information, and we look at the same information each time, and personally I find it very helpful. But there is a risk that it's the same information, or it's just a sort of slightly different version as each quarter passes. And the big risk there is that I make the same comments at every meeting, and and so I just wonder whether we could head off that possibility by, for example, if you take the
tests that are set so that we can take that forward. And on the civil enforcement side, one of the things that I think sits underneath the radar for people is the amount of activity that's going on in civil enforcement, which we cannot make public because we cannot kind of share that information until it's all been completed. And if there are representation, so providers query what we've done, or if there are appeals to the First Tier Tribunal, this can spin this out for quite some period of time, and that is an impact, and it's one of the reasons why we would really like to have the regulations changed so that we could make that public, so that the public could see that we were taking action, even though it was not complete. There there is controversy about that, as I'm sure you can imagine from providers, but there is something about us being able to be a bit more transparent about that. The second point around progressing through the warning notices in particular and making sure that we're doing that in a speedy fashion. We have been improving our data collection and data analysis around this, but there is a problem that on some occasions we're not closing off the enforcement actions in the system so that we can demonstrate that it's been done. You know, when we've gone in and done our quality assurance, we are finding that actually things have been done in a timely fashion, but we're not actually demonstrating that in terms of the way that we're managing the system. This is something that Debbie in particular has recognised, has raised as part of the Enforcement Oversight Board. There's a whole series of work that is going on to validate that information and to follow up on it. And we've had a conversation with Gavin Kennedy, who does all of the kind of hard work behind presenting this report, and we will be able to bring to the September report a more detailed breakdown of some of that information, which I think will help. The bit on the breaches, again, what's reported in here is that we were at 10%. There's been further work done, and I can tell you that we're down to 4% of those services that are in breach for more than 4 quarters that don't have an action plan against them. And there is work that is going on to address that. Some of that is data issues. You know, we had services in there which weren't actually adult social care services, so hospices, because we transferred those across the hospitals. There are still, again, some issues around us closing things off in CRM, but there are issues that, I mean, in PMS, they have identified a number of services that are in the process of deregistering, and so that's a category that is included in the PMS. We decided not to do that in adult social care because we get an awful lot of providers telling us that they are deregistering and then they don't. And there's a kind of, a bit of a recycling of that going on. So that we don't kind of think that that's all fine and dandy, we're keeping on top of that. But there is at least one of the cases up in the north where we have identified the location is vacant. We are actually progressing to cancel that registration. So there are things that are going on, and the heads of inspection and deputy chief inspectors are all over it. The final point, which is linking all of this in terms of impact, I do think this is maybe something that we could think about for a regulatory governance committee session, Lewis, which is obviously in your gift as chair, to actually think about how can we do some of that more rich connecting of the dots, to think about both what's the impact, what change is produced. You can see in one of the other slides that when we go back to services that we've rated as inadequate, the vast majority of them do improve, and an awful lot of those will have had breaches, will have had enforcement action taken against them. We see less, we do still see improvement, but at a less high rate when we've rated services as requires improvement. But I think you're right, something that helps us to join all of those things up and really explore that further would be helpful.
So I think what I heard you say was that you do have confidence that our teams know what is happening in response to either a warning notice or a provider that's been in breach for a long time, but somehow some of that isn't getting recorded. So it's primarily or entirely a recording issue. If I heard that right?
Yes, and what's been great has been that the improvement in the data collection and presentation of information through the dashboards for inspectors, and then the kind of performance reports that are coming through to inspection managers, heads of inspection, myself and my senior team, has improved immeasurably over the last couple of years. And so even if individual inspectors weren't picking it up, there is a process in place that means that we are seeing that, and that's one of the reasons why the 10% has gone down to 4%, because people have gone back and asked those questions. So, pay tribute to the team that's been developing that to help us manage that in a much better way.
Thank you. Kirsty, I don't know if you were offering to provide the answer or whether you were raising a separate point.
No, what I was just going to say in response to Lewis's challenge about pulling the data together is we have already started a piece of work to, and it's not just around enforcement, there's a whole load of other areas where we can start to be a bit more intelligent in how we use this information to present the sort of so what questions. So Gavin is doing that as we speak, and the other piece is actually trying to look at how we use this information more effectively, so bringing back some deep dives into certain areas to really drill down but give you the information in a way that prompts the question, so it does the analysis for you as opposed to having to put all the bits together to ask the questions.
Good. Paul and then John.
Just the point that Andrea made about the delay caused by the transparency problem and us not being able to say about it and saying there needs to be a change in regulation. I think this is quite an important issue because the transparency is what we're about, and if there's something getting in the way of that, and there seems to be a perverse incentive on the provider to elongate this. Because nothing will be seen by the public while this goes on. I think we do need to talk to the department about those regulations, and I think it's something that the Health Select Committee will be interested in because, in a sense, the whole burden of where the whole system's going is around transparency, and something getting in the way of that is a problem.
To reassure you, Paul, we have indeed raised that, and there are ongoing conversations, not just about that specific regulation, but others. But if I had my top three preferences of what we might want to sort out, that would definitely be in it.
Very, very quickly, Peter, building on what Kirsty just said, 21% of services previously rated good deteriorated. I wonder if you're doing any analysis that would give us some red flags that would help inform an intelligence-led strategy as to who might be wobbling.
Malta.
Thanks, John. I can't give you the answer whether we're doing it, but I'll explore and get back to you on it with the team. To do that, also just because it's important that we're clear, it's 21% of services that we re-inspected who were previously good, not 21% of all services in the country. So it's an important distinction, but we'll take that away. It's a good question.
And if I can add, in some ways, it's a testament to our intelligence-driven approach because it is a reflection of the information that we are getting that is alerting us to a level of risk in those services, which is meaning that we are going back out to them earlier than we might have done, given that we'd rated them as good, and therefore picking up those problems at that stage. So there's, I think you're right that we need to be getting underneath it, and one of the things that we're going to talk about later, which is the work that Helen is doing specifically around registered managers, that's absolutely a flag. But it is a response to risk being raised with us that we're going back out to those services.
Andrew, can I just raise one other thing that just surprised me, really? We on the risk register, we have an amber risk rating after mitigation that we would fail to have spotted a hard-to-replace provider. Now, I presume that this is since we only have the responsibility for that, and anyway, hard to replace would be in the market oversight scheme. And I have huge confidence in our market oversight scheme to spot things. I mean, we may or may not have issues around exactly how the regulation is scoped, but that is different from a failure to spot it. Am I misreading this, or are we doing ourselves a disservice by having this at amber when I think it's probably at green?
If you look at the way that we've rated that, Peter, the likelihood is, in terms of after mitigation, the likelihood is low, but the impact remains high, and that so I think that there is we are taking into consideration that we don't think the likelihood is low, but clearly if it did happen, the impact would be high. the other reasons that kind of lead to that is that we have documented our processes. We have there are various things that we are doing and that we have done and we're going to report on when Stuart joins us later for the market oversight item. But in terms of fully testing the whole system and going through that, then I think that applying a level of caution around that is appropriate. And as Stuart has identified in the report that we're bringing to you later in the agenda, we do still have a significant resourcing challenge within market oversight, given the pressures on the team, and we have now got the permission to increase our establishment so that we can cope with that. So I think those are the aspects that are guiding our thinking. The other aspect of it, although in some senses this is a risk which is not our risk, but there is a risk around sort of what then does the system do about all of this, and the contingency arrangements being led by the Department of Health and Social Care and other appropriate bodies is something that again is not completely fully tested. So I think it's right for us to have a level of caution, but after mitigation we would be expecting the likelihood to be low, but it would still be a high impact.
I can't argue it'd be a high impact. You might like to look at the words to spot, because I just
happy to do that.
Thank you. Made me happy, Steve.
Because I haven't said anything, I'd like to just say something.
It's not compulsory to speak.
No, I was sort of feeling a bit sad we hadn't said anything about primary care. So our performance has done pretty well on this year on report publication, whatever. But I just want to. We don't focus in the qualitative side of this discussion, which is always on quantitative and on data. But we've got a number of GP surgeries which have done exceedingly well to go from inadequate to good in a year, in the past year. And this is the 4-quarter review. There's one today that's come up called the Droylsden Road Family Practice in Newton Heath, where Man United were created as well. They've gone from inadequate to good in a year, and I think that's down to superb leadership. And I think sometimes we should mark our performance by reflecting the performance of providers which have turned round care in really difficult areas.
Can't disagree with that. But don't blame us for spending most of our effort commenting on the data that you've supplied us with. So, anything else on the performance report that anybody would like to raise? Excellent. So we're in good shape. Yeah.
Oh, let's do the money.
So we did the money? Yep. Kirsty.
Okay,
because you asked for the performance data, you asked for this data as well.
Yeah, no, we get it.
So just in terms of the money, the headlines are, because this is the final quarter report, that we drove down costs in 2017-18, and we are continuing the trend that we started in the previous year. Overall, we're underspent against our budget by £6.3 million. That's 8.6 million lower than our budget, and then which was reduced by another 2.3 million due to under recovery on fee income. So what we've done is our reserve for our retained earnings has now increased to £15.5 million. So overall, pretty good performance in terms of finance for this for last financial year. In terms of finance position, I think we've been looking at the underspends and where they've occurred, and what we're going to do about it in future years. If that happens again, this year we took money off in year as underspends occurred and held those in a central fund, which is why if you look at the finance performance report, the other looks quite significant in terms of the variance and underspend, because that's where we held the money that we'd retained, and then we held it and put it back out to the business where we had a need to spend. So in terms of this year moving forwards, we are slightly overspent on our first results for this year. We will do a full forecast at the end of this, when the accounts close down for this month, to have a look at what that means moving forwards. But at the moment, we're not worried in terms of where we are. But just to say, I think the overspend has come from a few things that have accrued, that have come forward from the last financial year and into this one. So it's not looking too bad at the moment. So overall, it's a fairly positive picture. We are now starting to think about how we budget, how we allocate our funds and business plan for next year, and what we do around that in terms of having a more robust process around managing money to try and avoid us getting into the underspend situation in future.
Just to pick up, Kirsty, on what you're saying, you mentioned about the 15.5 million retained reserves. I think it's worth pointing out, I think I'm right in saying that is really just a timing feature, in that where we are collecting more money than we are expending, and we're doing that partly because we're driving down our costs, but also because there are other costs coming through that we will be wanting to spend that on in order to improve our services. So it's not that we're building up things to pay dividends or something to people. We're building this up because we've got some costs that are coming through, as you said, maybe some of them slightly delayed from last year, some of them to do with the strategy implementation, where we need to deliver some kit and systems and stuff like that, which is coming through in this year and beyond. That's right? Am I right?
That's absolutely correct. Yeah, we're not piling up a big pile of cash. It is to fund all our digital improvements to drive efficiencies further forward to help us not have to put up fees in the future.
Yeah, good. Thank you. Anything else for Kirsty? So, unless we're going to spend half an hour talking about the ACGC report, well, be careful what you wish for, Paul. It might be helpful, Naomi, if you could get a message, if you haven't already done it, to Imelda that we're miraculously running ahead of schedule at the moment. So, Paul, back to you.
Thank you, Peter. This meeting, there's a synopsis of what the items were that we covered in here, and I suppose I'd pick out a couple of points which are worth just emphasising this. One is looking at the NAO and Public Accounts Committee action plan. We spent some time, particularly here, around, I mean, I addressed it earlier with Ted around the hospitals, the issuing of reports on hospitals within a timely fashion, and because that's one of the areas that I think that both NAO and PAC have highlighted. And it was quite a useful discussion. As Ted reflected, we think it's a pretty tough ask to get all the way to our target within the next year, but we need to make significant progress around that, and I think that's quite a useful discussion that we had about that. And then we spent a fair bit of productive time, I think, on looking at the governance and control and management, really, around particularly around the agile projects within the IT function. There are different aspects of systems and data and information technology that we need to separate out, but particularly looking at the agile projects, where we've started. We are building up a capability within that. We're starting to build up one or two products that we're actually producing around that, but it will become a way of working for us in the future around the development of new digital capability. And we need to make sure that we've got in place the right structures to both enable that capability to be done quickly and agilely and in the right way, but equally to make sure that we are on top of what's happening and we are managing and governing and controlling that in the right way as well. And we've learned quite a bit over the last couple of months in terms of what we're doing there. Some of it's good. We had a review by the internal audit, by some specialists from within internal audit to look at this, to give us some pointers as to what we might do better. And I think that was a very valuable review that was done there. It's not an audit as such, it's a review because it's an early stage thing to help us with those controls. And out of that, I think, has come a number of areas to look at. And I'm glad to say that you know, Kirsty is picking that up with a view to actually looking at, you know, what are they, defining what we need to have in there and making those processes as agile in their own way, but also as automatic as we would want to have, so that we can assure ourselves that we are on top of what's happening there, and that we spend the money wisely, that we get the results that we want out of it, and we get it out on time. So that's coming back. Kirsty's in the process of looking at that. Will come back to our June meeting of ACGC. It won't be complete there, but it would be the challenge was to Kirsty to show us progress along that line by June, and I'm sure she will. So those are the 2 points that I pick up.
Thank you. That's really good. Anybody want to raise anything? So thanks, Paul, and thank you in advance, Kirsty, for what you're obviously going to be doing. Fantastic. Good. So we move on to the Healthwatch England update. Welcome, Imelda. Nice to see you. Jane, are you say anything by introduction?
If I might, yes, please. Yes,
if you turn your microphone on, you may.
Thank you, Chairman, very much. And first of all, just to remind ourselves of the rules of engagement, which of course is that Healthwatch England has its own independent statutory powers, but we are a subcommittee of the Care Quality Commission. David Bean is our accounting officer, and Imelda is the accountable officer. And having done all that formalities, I think I would like to say thank you very much indeed, because this relationship could be one where we spend a lot of time going, well, you're telling us what to do, but in actual fact it's incredibly helpful, not least because around this board you spend a lot of time doing governance, which means that at Healthwatch England we can get on with the job and spend our time mainly looking at what people say to us and what we can, how we can best pass that on. So thank you very much indeed. The paper comes in two parts. One is sort of an update, and the second is the strategy. Just very briefly on the update, you'll see there local Healthwatch funding looming large there. It's a very interesting debate at the moment, because it's about, is this about local authorities? Is it somehow the fault of local authorities, or is there something else going on out there? And just, we were talking the other day about what's happening up in the northwest, where Healthwatch Cumbria has now taken on the contract for Healthwatch Lancashire. They have found, interestingly, that whereas Healthwatch Cumbria is very strong on strategy and partnership and meeting and talking with the big beasts up there, Healthwatch Lancashire is actually very, very good at engagement. And so, although it feels like maybe it feels like a takeover, they're going to benefit each other. So there's a lot of churn going on in the marketplace out there in local Healthwatch. Some of it's to do with local Healthwatch funding, but a lot of it's to do with actually coming together to strengthen our offer. I'll let Imelda talk more about the mandate and our mental health watch, mental health programme. And I would just like to draw your attention to the Healthwatch England staff survey, where I'm pleased to say we have a very happy ship. We also, though, have, I've just introduced 7 new committee members, and that's providing an additional level of challenge, and we're going to be working, David's very kindly offered some help, to make sure that we sort of really get the best of some very interesting people with lots to offer, but it's finding a way of how to make sure that they can offer their advice and work happily with all our wonderful staff. So that's the update, and I hand over to Imelda, if I may.
Thank you, Jane. I think I would just spend another moment, if it's okay, on the funding of local Healthwatch. Just to remind you, the money comes from Department of Health through then to local government, and obviously isn't ring-fenced. We've seen a 37% cut in funding since Healthwatch was first set up, and the funding that was originally put in place was there was the amount that went for Links, which was the body that went before Healthwatch. And then there was additional money put in so that we could take on the additional statutory responsibilities. From this year now, our overall funding is lower than the links level. So I think we're actually at a real crunch point about how we handle the issue around funding. There are 81 Healthwatch which are now receiving less money than they were when they were links or when the predecessors links. We're raising it with the Department of Health, with the sponsor team, and next week have a meeting with the ministers, 2 ministers that have responsibility for Healthwatch, on the basis that this is the department's way of making sure that the views of people are at the heart of health and social care, and I think we're at a very precarious position at the moment. So I just thought you should know that. The rest of the report I'm very happy to answer questions on. I'm assuming you've read it.
Definitely guarantee everybody's read it. Robert?
Just taking up your point about funding, Imelda, is there any prospect or any consideration being given to changing the route of funding? It seems to me that what's happening is that the reduction may not be so. I don't know how much the reduction is from what comes out of the department, but it's actually seems to get filtered away from Healthwatch once it gets to local level for reasons which are pretty obvious when you look at your council tax bills.
Yes, exactly. We understand exactly why it's happening, but nevertheless there is still a commitment to putting people's views at the heart of health and social care. There are lots of people within the network who would love to change the funding model, but that would need legislation, and it's just not a run. I'm not having those conversations at the moment. We'll have conversations about whether there are other funding streams that can support the work, because it's entirely from local government at the moment.
So Mel, you say it's entirely from local government, and that's entirely as far as the statutory funding is concerned. But am I right in saying that at least some of the local health watches also raise money locally?
Yes, they do. Yes, that's quite right. So some will take on additional contracts, some take the advocacy contracts, some have complaints contracts, some will take on contracts for specific pieces of work, and their core funding that sustains them and their statutory responsibilities is the local government grant. That's correct.
Good, thank you. Lewis.
This is not about funding, this is about in general. I'm sure I should know this already, but when there's a report which says, as this one sounds like it will say, that there's a problem of GP access, and also there are some interesting points made in the mental health section about actually something I've not heard before, which is people saying that they feel that primary care, general practice, has become a real, a very useful resource, the go-to place, I think you refer to it as, in mental health, whereas actually the story out there in mental health is that secondary services are asking primary care to take over the care of individuals a little bit too quickly. So if what you're hearing is something different, that's quite an important message. But my point is what then happens? So if your report says you have evidence, you have information, you have reports about poor access to GPs, a very, very familiar theme. I suppose one of the most familiar themes. Is there a requirement to respond? What's the impact of that? Is it just go out there so that people read it, or what's the actual mechanism through which that might influence practice?
Well, I'm going to let Imelda give you the substantive answer, but the initial answer is that it's our job to provide this evidence. And then it's our job to just offer it out there and to make sure that we offer it in a way that the right people get to hear it. We don't just sit on this evidence, we pass it on. But Imelda will know who we pass it on to and how, because we do it in a myriad different forms and at a myriad different levels.
I think you're asking a really important question, which I've been asking the team myself, which is the so what. So we know this, so what. And I think there's two things that we need to do. And one is, we know that people are finding it difficult to get access to their GPs, but that's not everywhere and that's not everyone. So where is it the problem? So then how do we get that piece of information into that part of the system? Then there are the other overarching themes, or some of them actually that tell us a different message, like the mental health one. And what we'll do from this, because this is the first time we got to a place of what do we know? From this will come a plan of, so now we know it, what do we do? Who needs to know this? How do we get it embedded into different parts of the system so that change happens? And that's what the team are working on right now. That we'll meet with mental health policy leads. We'll issue papers on it to the sector. Yes, but does anyone have to do anything about it? Is that the...
I suppose I'm thinking that there are, we're in a world where there are quite a lot of reports, and one or two of these issues are incredibly important. But I suppose I've highlighted one that isn't new, and therefore the implication is that the response has only been partial until now. That might be putting it generously. And one of the messages is new. But either way, there's something for people to respond to, and there are certain sorts of report that require a response, and there's a sort of duty to respond, and there are others which are just sort of respond if you want. They're quite interesting to hear about, and given the status of Healthwatch and the importance, I suppose, of where it's getting its information from. There's just a question which I'm admitting I maybe should have known the answer to already, but about what should happen, what could happen if people are kindly disposed towards it, but what actually should happen.
Yeah. I mean, well, two things. One is, with your permission, Chairman, one is that the mental health, we've got a big focus on that at the moment, led by Liz Sace. And that's absolutely to make sure that we have a focus on what people are telling us and making sure that their voices are passed on. But the other thing is the sort of information that we're sharing are stories. And in a way we're hoping that, and it does seem to be the case, that if you present to people a real life story, they are more likely to react to it and more likely to go, right, that's a problem. Yes, I know I can do something about that. So I think where we're different is that we're not just about reports and statistics and graphs and diagrams. We are very much about stories of real case histories which people in the system, providers, can react to and perhaps do something about.
Up on that very quickly, and it depends on the type of report it is and where it goes to whether or not they have to do something with it. So with the local Healthwatch reports, particularly around enter and view and the reports into the local government, they have to respond within a period of time to acknowledge it and to say what they're going to do. For ours, there are certain things that they have to respond. We're one of the statutory consultees, so like on the mandate, and they have to respond to it. It's a very good question to ask whether they have to respond when we send in a paper on, let's say, what we know about mental health as a particular briefing. Not talking about the big reports, but at the end of this year, this is what we know. I don't know, actually. I'll have to go and ask. Do you know, David? Do they have to respond? No, just the mandate stuff, I think. Just this, yeah.
One of the ways in which you've been phrasing it is they have to respond.
Yeah.
But what about we?
Yeah.
Have to respond, right? So if we're going to give you legitimacy, we as the CQC should respond to your report.
Yes.
Not because we have to, but because we should.
Yeah.
So, go on, Ted.
Well, first of all, thank you for all the feedback that you supplied to us, which is really very valuable in terms of our role. Yes, sorry, turning my head both ways. But can I just ask a question about our reports and how useful Healthwatch finds them? Because we sometimes get a lot of engagement from local Healthwatch when we publish a report, sometimes we don't. And the kind of sense is it helpful in terms of Healthwatch taking its agenda forward locally when we've reported on a local provider, say? And is there something we could do differently, either in the report or the way we present the report, that would actually help you be more effective locally?
There's a complex answer to that. One is at a Healthwatch England level and CQC at national level. I think we work really well together, particularly in early stages of reports, and that I think is improving all the time. And so it's incredibly useful to us. the work that we'll be doing on mental health will be a lot framed by the work that's already done within CQC. At a local level, it's various. It depends a lot on personalities. We're doing quite a lot of work at the moment with the engagement team to help streamline the way that inspectors can relate to local Healthwatch, knowing the pressure they're under and knowing the pressure that local Healthwatch are under. In some places it works really very well, and there is a monthly meeting where they share reports or what's coming up. In other places they have to go find that work that they know when the public knows. But we're trying to make it more systematic.
So I suppose my question is there anything we can do that will help local Healthwatch do that better?
I think just sending back the message through your teams that it's important that we work together and that we find a way of systemising it so that it happens all the time in the right way.
Andrea.
Sorry, excuse me. Thank you ever so much, and thank you, Jane and Imelda, for the report. I just wanted to pick up on one aspect of it, which was, as you might imagine, the work that Healthwatch are doing on quality matters in social care and the leadership role that you've got around Priority 1, which is around improving complaints handling in social care, which is mentioned on page 5 of the update report. And thank you for the work that you're doing on that, and it's been great to be a part of that with you. But I was just reflecting that it doesn't seem to be in the business plan for the coming year in terms of there being a deliverable around that, and just wanting to kind of understand what it is that you're expecting will now happen with that a particular aspect of your work, and how we can be assured that it will be taken forward.
Yeah, I can assure you it's being taken forward and it is a priority. It isn't in the business plan, but it is in the work plan that sits underneath it. There is a broader heading about partnership working and a broader heading around working across the system. And under that, there are lots of plans, one of which is Jacob leading on quality matters and complaints. It's in his work plan specifically.
Thank you. I shall look forward to it then.
Imelda, can I I'm not sure I'm asking a question or just raising a point, but I have difficulty at times in contextualising some of the data that you've got, because by definition this is just what you have been told, and that is a self-selected group of people that tell you. And I'm having difficulty in knowing in some of this whether there is a significant deteriorating or improving situation, or whether it's just a bit of sort of random feedback. So if I just give one example, under the secondary care key themes, you say people have continued to tell us about poor quality of care provided in A&E departments. And I'm sure they do, if that's what you say. But if you just read that at face value, you would think, gosh, that means that the whole world thinks that A&E departments are looking after them badly. My probably even less scientific personal experience from talking to patients in A&E departments is that mostly they think that the doctors and nurses there are great. Whether Ted and his team would agree or not, most patients that I talk to really happy. So it's this contextualisation. I don't know whether there's anything we can do about that, but so it may just be a statement, but if you've got anything like that.
I think that's very helpful. This is the first time that I've had a look at a whole year of data, and my honest view is that we need to do some serious work to look at the context of it, what it's telling us and where, and is that the right place to look for the information, or is it somewhere else? Because actually in the reports that Local Healthwatch produce, there's far greater depth. So if I give an example of Worcestershire, went and spent quite a considerable time in their A&E department. So the report that came from it has huge amounts of depth. Enfield spent a whole week in their A&E department. So again, you get much more nuanced debate. Whereas if you're just getting the what do the public say, then you just get we're not very happy, we've waited too long. Or actually, you get quite a lot of it's great. So I think that, it's about how do you get to the stuff that helps change. And I think that's often in the reports rather than the individual feedback. So I think we're going to have a look at how we shift the emphasis onto some of the reports, the findings of reports as much as individual.
Really interesting. Thank you. But also how it fits in with other data. So I, like Lewis, I think it is really interesting that you are saying you're getting people saying we're getting better access to GPs and mental health services. Now, there may be other bits of data saying that, but I've not come across it. So this is so either you're the beginning, because probably your relationships, your information coming in will be new, will be sort of near the front end of rather than actually a lagging information. And so that could be really quite useful. You're getting newer information in, but there will be a lot of information about that out there. And just saying we found this, others have said that.
Completely agree. And so in the new strategy, we are clear that we will be using a lot of other people's data too, and we'll be setting ours alongside that, so it can tell us what's different, or whether if we're just agreeing with what everybody else is saying, then that's just a sort of an add-on, isn't it, really? But completely agree. So, yeah, that's a major piece of work in this coming year.
Just pick up on these points. And the point that you've just made, Paul and Lewis, we were talking earlier about subjective truth, and then there's this point about triangulation. And it seems to me that the relationship between Healthwatch and CQC is a hugely important one, and this flags it in that sense. And I'm struck today by the news from the Professional Standards Authority in relation to the regulation of NMC and Morecambe Bay. If I remember the James Titcombe story, and I think I do, it was something like a 96% satisfaction of maternity services at Morecambe Bay. The question was, what was in the other 4%? And those individual stories are often what's in the other 4% that then need to be triangulated against the 96% that are satisfactory. I think Carl Hendrickson, whose story was on the Today programme this morning, talking about the loss of his wife and baby, bring these out for me, which is why you need the individual stories, subjective or other truth, alongside the data that comes along, and that's where I think we've got to ask the questions, what does this mean, just to put the point on. So it's not just the data that Imelda and the local Healthwatch teams generate, it's also contextualising that and beginning to draw it together. And I think that's the conversation we're going to have later today about intelligence and how we draw data together, is how we do draw those different data sources and begin to make the connection with our assessment. And there's as I say, I'm struck by the poignancy of the stories from James Titcombe and Carl Hendrickson this morning being told, which remind us of you need multiple sources to arrive at assessment about whether something's okay. Some of them will be picked up locally and some of them will be picked up through our inspectors operating locally, and it's that relationship that's a critical one in my view.
Lewis, one brief one. I mean, I was interested, just there's one line in the description of the work programme, which is about making sure you heard from young people, and I'm slightly paraphrasing, but there's an emphasis on young people. And I suppose it relates to what we've just been talking about, but a slightly different aspect, which is the need to have a balanced demographic in when you're hearing from people and translating what people tell you into something which is a broader message. You have to understand who it's come from and who's not there, and as well as who is. And young people, I suppose, is a very good example. It'd be very surprising if ethnicity is not also an issue, because it usually is in questions of representation. So there are two groups. Young people. You might say older people as well. I don't know. There's there's a certain demographic that puts themselves forward, and at either end of the age scale, you tend not to get that. So, first of all, I think that's a good thing. I'd wonder whether it should be a wider thing about the broader balance, rather than. Young people is great. I strongly support that, but the broader balance, because there are other groups too that might not be there, and whether or not there's a way of formally checking. You've obviously got a number of KPIs which you are following. I might have missed it, but that doesn't appear to be one of them, even though that's, I think, a really good thing for you to be doing. And I just wonder whether that's something that could be given more strength, more impetus.
Just very briefly, it's a very good point. what has always been the mantra of Healthwatch England has been to look out for the hard to reach groups on the basis that if we could solve problems for them, we'd be solving issues for everyone. So we do, yes, we do look at all across ethnicities, all the protected characteristics, and we have several members of our committee who are particularly strong on making sure that we do so. I think the bit about young people was just that young people have, particularly at the moment, are coming up with, all over the health watches, all over the country, some of them have youth champions, some have people out there doing films, doing all these wonderful social media things that people do. So I think they're a particularly interesting group for us to latch onto. Especially because they're coming forward very strongly to say that they, on this prevention business that we were talking about earlier, they don't want to get ill in the first place, particularly on mental health. They don't want to get ill. They want to be helped to stay healthy. So I think that was our particular link in with for young people, sort of to stop them becoming, customers of the future, basically.
Okay.
KPI, gosh, we've discussed KPIs. We're not there yet on KPIs, but Imelda, do you want to comment on that?
KPI, what we're doing, which might be of interest to you, is that by July we're going to have taken all our data and started looking at it in terms of different representative groups. I think what we'll find is that we don't know a lot, to be honest, in the individual pieces of information that come from the public, because you have to fill in a lot of detail. But the reports, again, I think will be where we'll find our nuggets of gold. So very happy to bring back the sort of exploration of equalities report to hear if that's useful for you. And then from that, we'll know what we need to be doing for the future. At the moment, we don't quite know, but we could put it in as a we don't know baseline, couldn't we? That would be all right. Very happy to do that.
So, Imelda, firstly, congratulations on all you've done on the first year you've been at Healthwatch. And secondly, looks like you've got a busy year ahead of you, but it's really great. So thank you very much for the update, but more particularly, thank you for all you've been doing.
Thank you.
Really good. So, we move on to the market oversight update. And Stuart, you're extremely welcome, and you might want to move into Imelda's chair so you've got a microphone. Andrea, are you going to say something by way of introduction?
I'm just going to kick it off, thank you. I want to just say a few words before I ask Stuart to present the report. Just for the board, the purpose of the report is to ensure that you're aware of what the market oversight team is doing, as much of it is necessarily, because of the commercial sensitivities, remains very much below the radar. But in doing that, I did want to pay tribute to and say thank you to Stuart and the whole of the market oversight team for their hard work and, frankly, diligence in what can be a very difficult job and under some very pressurised circumstances at times. So thank you, and sparing you any further blushes, you can start to present the report.
Thank you. Prior to responding to any questions that board members may have with regards to the update paper, I just wanted to take the opportunity to make board members aware that Market Oversight issued its first Stage 6 notification on Monday of this week. As you are aware, we make such a notification once we've satisfied ourselves that service cessation is likely as a result of likely business failure, and that the purpose of that notification is to allow local authorities to ensure continuity of care for all impacted people using services. Yesterday, administrators were appointed over 2 Orchard Care subsidiaries. Monday's notification was only to Darlington Borough Council and related specifically to a single location called St George's Hall and Lodge, which is an 83-bed nursing home operated by Orchard Care. Our notification was therefore proportionate and focused, since it related to the single location and one impacted local authority. The intention is for the other homes operated by those subsidiaries to be transferred to an alternative operator shortly. No other homes operated by Orchard Care were impacted by the notification, and we've since confirmed with Darlington Borough Council and assured ourselves that all parties are sort of engaging in the sort of process to preserve continuity of care. If I now turn to the sort of accompanying paper that we've sort of provided, that obviously relates to the May 2018 quarterly market oversight governance process. If I sort of pick out a couple of highlights, clearly activity levels have increased. The drivers of that have been twofold. There's been an increase to the number of names covered by the scheme as a result of providers satisfying the entry criteria. And secondly, there's been a general increase in risk across the portfolio. That sort of increase is again twofold. One is a sort of general increase, and the sort of second is that we have a number of names which are sort of currently operating at an elevated level of risk within the portfolio. We will therefore, or the intention therefore, is to take the opportunity to review the sort of guidance and sort of legislation that we sort of operate within, both on the back of now having made our first Stage 6 notification, but also having sort of run through the continued sort of live elevated risk situations. I wasn't going to sort of go into further detail on the paper, but instead use the balance of the time to take questions. So without further ado, if anyone has any questions, I'm quite happy to field them.
Paul.
Thank you, Peter. Thank you very much, Chair. Thanks for the work that you guys are doing, because I know you're working really hard on all this stuff. The question I've got is around the direction of travel, if you like, and where we are in terms of, we've referred in reports in the past to tipping points, and you know, what the dynamics are going forward. You've mentioned the increased number of operations that are within the portfolio and the increased level of risk within there. You also note the potential risks around sleep-in catch-up payments that might be going on. There's the timing of when those might happen in the future. I just wonder if you give us a sense of what the direction of travel and the dynamics might be around the marketplace as a whole, and whether it's the marketplace as a whole or just a few providers within it.
So there is no doubt that we are now seeing the consequences of the sector having been funded at a level that allows it to limp along, actually manifesting itself. And I sort of say that not only because of sort of a number of elevated risk situations that we are sort of currently dealing with, but also certain behaviours that are sort of obvious in the market. And I have in mind there wholesale corporate sort of exits, contract sort of handbacks, but also business being taken on a marginal cost basis. So what that sort of means is that operators are taking sort of decisions that in other circumstances they wouldn't be inclined to do, and they are only doing that to try and sort of bolster the economic viability of an existing operation. The final related point that I would make is that if one focuses solely on sort of local authority facing services for care homes, for instance, the market has not seen any significant investment in that sector for a number of years because sort of the economics don't work, and there has been sort of increasing concern amongst operators and investors given sustained austerity. The importance of that point is that if one looks at the CQC bed data, then whilst that has been evidencing some decline and it may have sort of flattened out, it's difficult to be definitive on that point given the sort of lag in our registration data. But even if one assumes that sort of the bed data has flattened out, that masks the fact that the beds coming into the sector are heavily biased towards self-funder provision, and those leaving the sector are heavily biased towards local authority provision, again, for the reasons that I've articulated.
So the implication of that is that it's continuing to get tighter and tighter in
Correct.
terms of the risk, and the tipping point we referred to is still very much coming at us rather than going or receding.
Correct. That would be my assessment.
Other questions or comments? You weren't here earlier, Stuart, when we were looking at the risk register, and I made a point. And I won't repeat the point, but in making the point, I said how the great confidence I had in you and your team in exercising the market oversight role, and I'd like to repeat that. Now you're in the room to hear it, and certainly from what I see, and I think David's nodding, sitting next to me, as in our governance role, we see what you do, and it's really impressive, and thank you.
Thank you, and I will message that to the wider unit.
So, are we done on that? Excellent. So thanks again, Stuart. Imelda, don't go, because David pointed out to me that when we were going through Healthwatch, I failed to ask you to note the budget and business plan, which we didn't discuss. I'm assuming that we didn't discuss it because nobody had any points to raise, but can we please formally note the business plan and budget? Good, thank you. Governance is working well under my chairmanship. Excellent. Yeah, I've got friends on either side to keep me on the straight and narrow, which is just as
got 14,
well. So Helen is about to come in. Helen, welcome. I'm glad your intelligence is so good that you knew we'd be running nearly half an hour ahead of ourselves, which just proves how good you are. Oh, really? So seriously, extremely welcome, Helen, and I think we just go straight over to you if that's okay.
So thank you for the opportunity to provide an update on the work that we're doing within intelligence. So this session is designed to give the board an update on the progress of the work that we've been doing within the intelligence team. And just so I get a recap that the development of the work that we're doing and the team overall is really central to our ability to deliver against our intelligence-driven strategy within CQC. And making sure that we're putting the right information into the hands of the right people at the right time to make decisions internally is going to be key as we move forward to make sure we can maximise the work, the impact our work has on people who use services. So the work we've been doing over the past 6 to 8 months has really been about focusing on laying the solid foundations, and I think the work that will come, and we'll talk about this, is really going to be about the impact now that those, the benefits those foundations will really have for us and the impact we can have with that work. So if I quickly move to slide 2, which just talks about what we're going to cover here today. In the autumn, we came to the board to describe sort of the framework for the work of how we're going to develop the team overall. And then in February, I gave an overview of the work underway in the data science space. This is sort of revisiting both of those and a bit of an update on progress. And also what I want to do is give some examples of the actual work that we've started to do, some tangible, so you can sort of see some of the impacts that some of the things we'll do will actually have. And a little bit of a view on how, alongside digital, we're now starting to engage the wider organisation in some of this work as well. So on to slide 3. I've started all of my presentations that I'm doing with the board with this slide, so hopefully it's just a bit of a reminder of the framework that we're thinking about, how we're improving the outputs that we deliver, making sure there's as much consistency as across sectors as we can, and driving that consistency across the operating model in the way we describe our intelligence. We'll only be able to do that if we get 3 enablers right, so the data and technology that we use to drive those outputs, improvements to the culture and the ways of working within intelligence and the development of the team, and obviously the impact that all of that will only be really fully realised if we've got the right cultural ways of working across the organisation to take advantage of that. So, on to slide 4. This is describing, revisiting the work that we spoke to you about in February. We talked then about some of the external procurements that we were undertaking alongside some of the more experimental work being carried out internally. Some of the examples later will just show you some of the data science work we've been doing internally ourselves. But here's a bit of an update on where we've got to with some of the external pieces. So, firstly, the expert systems work. This is really... so expert systems are attempting to emulate the capabilities of expert decision makers using artificial intelligence, and we've been running a scoping project with an external provider to help understand the benefits of that type of approach could bring to CQC, and what things would need to change, what enablers would be required to really make that effective. So they did a series of interviews across adult social care. We used that as our sort of focal point for this scoping piece. And there was a follow-up workshop which was attended by members from across the sectors. And I had some anecdotal feedback from that was a really sort of inspiring session about what the possibilities of this could bring, which is fantastic. We are expecting the final report in the next couple of weeks on that, and would be very happy to circulate that to board members to then allow us to think about what really we could do with this next and how we could take that forward more formally.
Helen, this may sound like a rather silly point, but I'm just intrigued. I mean, you throughout the slides, you're describing a problem and then how you're going to solve the problem. And I can understand from your point of view that's how you're thinking about it. But actually, it isn't a problem, is it?
No,
it's a huge opportunity.
Yeah, that's right. It's an intellectual problem.
Yeah, no, I
not
understand that.
An organisational problem as such. Yes.
But I think it's quite an important. It's not just a semantic, because I think these are huge opportunities for us that you're describing.
Yeah. Noted. Thank you. So that is the expert systems piece. The other thing I think that will give us is some of the conversations they've had is really about how decisions are made today, but also what data are underpinning current decisions. And I think that piece of work will be a really good head start for the data strategy work to come that we're going to do starting in the next few months. On the data science advice, that piece was all geared to training some of our more, sort of the statisticians and the more advanced analytical members of the team in new coding languages, and giving advice and support as we undertake the GP predictive model work, to make sure that we are using those new we're applying techniques that we know about in the right way with these new coding languages. So that training has been done, and the support is now starting as we're starting the modelling piece of that work. And the tech severity piece is going to be, we're going to see the first sort of version of this, or for early results from this in the next few weeks. But this is about, can we, as what we want to get to is a place where, as we get information coming into the organisation, can we quickly tag or identify those pieces that we're most concerned about? So is there an automated way we can do that? So obviously all our inspectors already get all the information as it comes into us, but is there a way we can really flash up and highlight the ones that we should have most concerned about, where it might not already be flagged in that way, and also allow us to look at items that are identified as high concern over time and across services, to see what information we can learn from that, and how that might help us with our risk assessments. So all of these pieces are not end results in their own right, but they're really going to enable us to do better things in the future if we can apply them in the right way. Okay.
Yeah, I'm okay. I think this is really great. Yeah.
And just to back Helen up on this, I mean, the people from adult social care that have been involved in it have been, are very excited by the possibilities. So it's kind of it's been really good work. So thank you.
And I suppose I was going to make the point later, but it's perhaps right to make it now. I mean, this is not going to be a straight line of unremitting success, is it? I mean, some of these things will not quite deliver what you thought they were going to deliver, and we need to be very prepared for that and actually regard that as a success in its own right, because that's where you learn and move on. So you've got dates by which things will have happened, and it'd be really interesting to get the reports coming back, but we shouldn't be dismayed if on some of the things you say, well, it didn't quite deliver what we hoped it would deliver, and we're now adjusting.
Yeah, absolutely. And the important thing for us is to learn that and apply that as we go forward.
Yeah, good. Paul?
And just on the last one on text severity, which is a frightening phrase, there's a what we're doing, if I understand it right, we're learning what are the words that are used that actually provide red flashing lights for us. There should be a feedback back to the public about that, shouldn't there? So that, in fact, if we get that right, then actually they need to know what those words are. So that it's not just an internal thing that we then have found out what they're trying to tell us, but we feed back to them saying, if you tell us this, then actually we know this is very serious, rather than just us. It's as if the text severity gizmo is trying to double guess the public, and I think I'm suggesting that if we say to them, actually this is what, then we don't have to double guess them.
Possibly.
We'll probably still have to double guess them.
Well, we still have to, they can assist us.
Yes.
They can assist us by saying the phrases and words that we think are red flashing lights.
Yeah, and there'll always need to be a level of validation, and as there always is around all of this. So when, we have to make sure that we're following up in the appropriate way from whatever piece of information we're getting.
But this is not private stuff.
No.
Because it's scraping public data.
Some of it will be things that a lot of it will be public data. Some of it will be things that we're directly notified of. But
it's private data from the public.
Yes. With things people are telling us, yes, in one way or another.
Great.
Okay.
Onwards.
So moving on to slide 5, I'm just going to give a bit of an update on some of the data and technology enablers. So we continue to work with digital to ensure our data and tech foundations are being laid to allow us to generate the high impact, timely intelligence for the organisation that we need to. Going forward, these key pieces are going to be governed under the Monitor Programme Board to make sure we've got the right governance and assurance of them. They're so crucial to us within intelligence being able to do the work we need to do and help us overall deliver a strategy. So that's something that is going to happen going forwards. In terms of the individual pieces, so my personal belief is that the qualitative text data is probably going to be the biggest thing that we can do this year. We've got a lot of information in the organisation, but it's not available to analysts at the scale that we'd need it to be available for us to use it appropriately, in an automated, at-scale way. And so really unlocking the value from that and presenting the intelligence from that to our inspectors to help them with their assessments of risk and ongoing monitoring is going to be, I think, crucial personally. So as I said, they already act on that information, but the ability to really wrap that into ongoing monitoring and use that look at that across time is going to be really important. So pieces of work we've got going in this space is we've got some external providers helping us basically create the right interfaces and APIs to pull core data between different systems so that we can really build it all into our one intelligence platform and make it available to our analysts to use in its entirety rather than individual items, which is where we've been thus far.
So is the ambition, it says the progress remaining 8 planned by the end of June. So at the end of June, is the hope that you're then able to get the whole lot to analysts, or is there a subsequent piece that has to happen?
So getting the 12 data sources means that it's sitting in a data system where our analysts can access.
Yeah.
And we are, as we go forward, we're testing different ways of using that now, so that as quickly as we can, once all of that's available, we can start to roll different sort of solutions out off the back of that data.
Okay.
Yeah. Well, there are more than so. There are the 12 priority. There are further sources that we want to get our hands on. So we're just trying to go about getting securing that external resource for a little bit longer to get us some of the extra pieces that we want to. That will take us probably through to September, October time. But the 12 most important ones are the ones that we believe we'll have by the end of June.
Paul,
could you say a little bit more about the sources?
Yep.
What they are?
So things like notifications that come through to us, complaints, whistleblowing, inspection reports. So it's basically anything that we've got in the organisation that's text data that's either we've generated ourselves or that have come into us. So NRLS, other sources like that. So all of those text pieces.
It's about trying to build relationships between all of those in order to be able to derive messages from it, which give us something that we can then use to act upon.
Yes. So today, for instance, when notifications come to us, they are stored as PDF attachments against a specific location, and they're stored in our CRM database. So they are PDF documents, and they are not in a system that our intelligence team can access, and they're not stored in any logical way where you could sort of read through all of those. So part of what we're trying to do here, is basically read those pieces of information and then store them in a logical structure so that we can look at that. So that's just for one source, and then we'll be doing that across sources so that we can use all of that together, as you say. Yeah. Okay. Then the next piece is around the iHub. I've talked about this a little bit previously. One of the big things that we need to do is make our work more efficient, and part of that is about bringing all of our data into one place. And it doesn't necessarily mean all in one big place. It might not be a huge data lake, but the iHub is, at the outset, a place for us to store all the standard data that feeds our current automated reports. We need the ability to link all of the data that we have around the different locations around providers together. And the iHub is the place that we're really starting to do that. So, as I said, we're bringing together standard data that supports our current products, and our plans for the future will be to allow us to easily link that to all the other data sources that we have, to make sure that we can do the analysis on the biggest, most richest set of data that we have. This is something that's been in progress for quite some time, and the PMS and the acute data sets, hub developments, the development itself is complete, and we're now in parallel testing. So we're testing the outputs that we get from the analysis that we're doing on that data to make sure it matches up with the way that we do it today, and that we haven't lost something in translation in building this new solution. Our hope is that will be complete by the end of Q1 for those two sectors, and then the remaining sectors will go through. So we'll iterate through them through to probably early autumn time.
Jane.
So, simple question. This is all sounding really good. How can Healthwatch help you? I'm presuming that you and Amy are in contact because we're collecting lots of data. Do you want to have access to that, or how can we help?
Yes. So I think the Healthwatch is one of the qualitative sources. So information from health is one of the qualitative sources that we're talking about. We're also we're in discussion around what is possible to share from an outputs perspective in terms of the intelligence as well between us and Healthwatch. So we're actively talking to Amy around all of this.
John.
Thank you very much. A huge amount of work that you're doing internally and trying to create this thing. I just wanted to ask, because it isn't here, how much or is anybody allocating your team to look outside? I know you've got connection with the Turing Institute, you told us about that before, but Jora gave us a brilliant example last time. Has anybody been to see it? Are there other organisations outside healthcare that are doing this, that the learning could be imported, aim being just to create a gearing effect on your implementation?
Yeah, so we haven't got dedicated individuals, but one of the things that we've been really trying to encourage over probably the last 12 months, and we're reiterating it, is the need to be curious and innovative and find out what others are doing, and you try and bring that into create learnings from that and bring that into the work that we're doing. So there are probably, I would say, 5 or 6 individuals across the team who are starting to have conversations outside. I mean, we honestly haven't got a formal plan around here are the specifics that we want to go and talk to. I know David and I went to the Met Office recently. I'd contacted the folks at Jora, put us in touch with after the last board meeting. With a number of us have different contacts from past lives that we are starting to talk to. So I guess that's where we're at with that.
I guess what I was prodding is whether it should be formally part of your strategy.
We're doing it. It's not a business plan deliverable that we're actually building all of those pieces in. But I think we'll take that on board. Yeah, for sure.
Okay, onwards.
On to slide 6. So a couple more pieces on the enablers, then I'll get into the exciting pieces, which is the work that we're, the actual tangible work that we're doing. So one of the other pieces is around the automation of intelligence outputs. I think a key principle for how we want to work going forward is that we automate. We look to build automation in as early as we can to the work that we're developing. We run a significant number of manual processes today for good reasons. Partly because of the data platform, partly because of the technology that we're delivering it in, partly because of just the inconsistency with that data that we're using. But we have a real strong ambition to make sure that we can automate all of the standard pieces as far as we can. It has proven challenging because, in particular, some of the pieces that take the longest time for us to deliver are the evidence appendices to support different sectors within the acute sector, different providers in the acute sector, in part because the data, because we don't have a digital collection for some of that information that comes to us, the data's in slightly different formats when we get it every time, and so it's actually quite hard then to automate a production line around that data. So we haven't made as much progress as we would have liked in the automation space. We understand why, but we're really keen to make sure that's a key focus, continues to be a key focus for us going forward. And then the final piece here is around an analytical environment. So we've currently got analysts trying to process large volumes of data using their sort of laptop processors, and with poor network speeds, sort of data being transferred around and processed in systems that aren't necessarily up to speed, just creates real inefficiency for us. So we've been talking about the need to create an analytic environment, a space, dedicated service space where we can basically do all of this work. And we've actually been in discussion with DH as part of this. They are running a proof of concept for an analytic environment in July, and they've invited us to be part of that, which is great, and that will help shape our requirements for this as we go forward.
I'm really very excited about this work about automating the evidence appendices because that is the heavy-duty report writing that is taking so much time at the moment, and I think that relates back to what we were talking earlier on, in that our reports are made up of a summary report, which is about judgment, and the evidence appendix. And the evidence appendix at the moment still is a very manually driven process. So I think there's a real opportunity to drive improvements in consistency to make sure that the evidence we're looking at is consistent between providers, but also improvements in productivity with the automation. So that's really a very exciting project, which hopefully can deliver fairly soon for us, because I think it's one of the things that's holding back the speediness of our reports. So I'm really excited about that.
Yeah, there's the speediness of reports, and then there's our ability to innovate further, because we've got people doing lots of manual work. We don't have the capacity for the innovation that we want.
So I suppose following on from that question is, are there things that the organisation as a whole needs to do to help you make the progress that you want to make in the timescale that you and everybody else wants? And if there is, if there's anything the board can do to
and I suppose linked to that, are there things the system should be doing, right? So presumably the system is moving the direction of sending us digital information, more digital information. And the quicker it does that, I think the more time they'll save, but the more time then we'll save. So it's actually how they can be encouraged to do that, because at the moment it's a burden, and it will be a smaller burden.
I think that's right. And some of the feedback we've had about our provider information requests is that they are burdensome, even though we're asking for less information, but we're asking for it in a very specific format. And I think we've had to be flexible with providers about the format they submit it in order to reduce the burden. But equally, over time, I hope they'll be able to collect that data internally in a format that can be rapidly transmitted digitally into our systems, so save work both for them but also for us. And I think it is part of our learning and our relationships with the provider sector to do that really well, both for their benefit and ours.
And that's certainly been kind of part of the focus of the work that we've been doing on the adult social care provider information return. Clearly we're expecting that to help us internally in terms of the use of the information, but one of the significant benefits will be to enable providers to have a digital relationship with us, which enables them to own the information and use the information as well, rather than it just feeding our beast. It's something that encourages improvement within the service as well, and potentially in the long-term future enables us to share that information with others so that they can use it too, which again will have an additional reduction of burden on providers. So there's a whole circle of benefit which we can be kind of achieving there. Yeah.
Right. Yes? No? Good. Onwards, Helen.
Okay. So into some of the examples of some of the work that we've been doing. So the first one is around our ability to identify where we think there has been there is an absence or a change in registered manager at adult social care locations. We know that the absence or change can lead to a risk in the quality of care at those settings, and obviously providers are required to notify us when that changes, but we know that doesn't always happen. And so one of the pieces of work we've been testing out is, can we identify beyond the notifications that come to us whether we think there's been a change or there's an absence of a registered manager. So what we did in this sort of test project was to manually look at job sites to see if we could identify where there were advertising registered manager posts. And use that information to create some flags with alongside our inspecting colleagues to understand what we think would be something that would give us cause for concern, and what would we be actually quite comfortable with given some of the information we know already. And those pilots were quite successful, and we developed some flags from the back of that. And so we've progressed from there now, going through all of the appropriate approvals internally around the data to sort of minimise any data concerns around this, and in line with some website permissions, there are a small number of websites that we're now starting to basically automatically look at to see if there are any of these adverts posted, which is a big step forward for us. We're using our new text analytics tool to do that automatically. So we've started that process. The data is starting now to come into the organisation, but I've talked earlier about the iHub. In order for us to be able to use this at scale, we need the iHub adult social care instance to be up and running, so that that data can flow into our data store, and we can generate the flags from it and push that into our standard insight products. I don't know if you've got a comment, Andrew, about this within the team.
Just to say that, I mean, one of the reasons why this one is so helpful, or potentially so helpful, is that we know that a change of registered manager, in any type of service, but in a good service, could be a precursor to a lack of grip on quality and a deterioration in the level of service. In the vast majority of cases, we will get that information and know that information in the right and proper way, but this gives us an added benefit of being able to flag up the potential that our existing rating can't be relied upon without further investigation because of that change. So if there is a change and we've not been told about it, then actually that would be a significant flag, and being able to feed that through into inspectors so that their portfolio management of individual locations can be more intelligence-led will be incredibly interesting to see whether it then has an impact on do we go out, and if we go out, what do we find, and so is there a kind of evaluation loop back that demonstrates that it's actually done the thing that we expected it to do.
And presumably this is just an example, I mean a very important one, but an example of probably what are a whole lot of other indicators across the sectors in due course that we'd want to flag. So Steve, a change of practice manager might be, I don't know, but it might be something we'd want to be sure we knew about. So if you can make this work for the registered manager, we can make it work for other areas.
Possibly, yeah.
Yeah. Only possibly.
Well, we can make it work. Whether it gives us useful information or not is another matter. That's
and I think
fair challenge.
It goes back to what you said, Peter, which is that we can have a hypothesis about what potentially would be really useful for us to have. We need to test that out both practically, but then also in terms of what does it actually mean? Because clearly what we don't want to be doing is kind of taking information into. I mean, I don't think it'll happen on registered managers, to be perfectly honest, but we don't want to be kind of giving inspectors information which is a false negative and takes them out to do inspections which actually are not required because, our inspection resource is a very precious resource, and we need to make sure that we're using it in the best possible way, which is what all of this is designed to help us to do.
Yeah, Robert.
Just on the web scraping, which it sounds almost worse than text severity.
I'll change the words that we use.
And I can see the importance of what you're seeking to do, but wouldn't a lot of homes be seeking to recruit managers through recruitment agencies with ads that are anonymous? And that might not help you, or are you proposing to web scrape, as it were, the home's own website, assuming they have one, and presumably some of the worst ones don't? So, I mean, how do you discriminate on that basis?
Yeah, so I think this is, if you think about what it will give us a view of when we think there's a change. So there'll be things there'll still be things that we don't know about, but this is something that we do know about that we can actively manage. This is our first foray into sort of web scraping, and so I think there's lots for us to learn around. Is it going to be possible to go to? Sorry, I won't use that term. Automating the ability to access information on the internet. Should we use that? I think, absolutely. There's all sorts of ideas that we'll explore as we go forward. But I mean, this is the sort of the first time we've tried that. But absolutely, we could look at that.
And I think, Robert, if you go back to what Helen identified on slide 3, in terms of, we've got the intelligent products and services, but those 3 enablers that. And clearly the data and technology, what websites can we go to, what can we actually find, the support that we might get from the intelligence team, but absolutely critically, what do we then do with it out there in terms of the registration and inspection teams? So on this one, what we need to make sure is that we don't kind of give ourselves a sense of false security that because we haven't been told that there's a problem, for absolutely the reasons that you've just described, we don't kind of give ourselves a false assurance that everything's okay. But where we do have that information in, it's an added insight that will help. And what is it that we're going to be doing with our teams to enable them to use this information in a way that actually helps them to do the right thing in a timely fashion, which is the reason why the evaluation of this is, the practicality of it is really important, but the evaluation of what we do with it and the impact it has is perhaps even more important.
Yeah. Okay, shall I move on?
Yes, please.
So the next one is around. We talked about this briefly at the board dinner last month. So I've included this. This is the topic modelling piece that David mentioned. So we've had. Actually, we're trying this in 2 different ways. So two of the analysts in the team have been trying to look at can we identify the topic that's being discussed when we get information. And we're through things like NHS Choices and Share Experience. So NHS Choices is the piece that we've looked at the outset, and we are attempting to build different algorithms that allow us to identify a topic based on information. So the idea would be, as information comes into us, we can effectively tag it with a topic that is like, with a level of certainty as to how likely it is that topic is as we define it, so that we can, again, pass that information to inspectors and they can see when a notification or something comes in. Notification is probably a bad example. When some choices information is now available on to us, without having to go in and read all of the different pieces, they can quickly see what the topic is and then decide if that's something they need to look at now or something they can come back to at a later time. We don't today, in the intelligence team, do any of this manually. So we don't create manual topics for many of these pieces of data. Largely, we don't do that. And so there's, these data sources have got huge volumes in them. So the ability to automatically identify or tag a piece of information would be really valuable. So just a brief example on the next slide of, this is slide 10, just what that might look like. So all the different blobs are different topics in some multi-dimensional space, so we won't go into that, but you can see this is an example of maternity service that says for the topic we've identified, you can see the red blobs, the red bars are the importance of that word within that topic. So within maternity services, baby, midwife and birth and the word experience, those are all words that really help us identify that as a topic around maternity. The blue bars are words that are actually quite important across lots of topics, you can see, so they're not necessarily the differentiator. So, you can see there's quite a bit of overlap with some of these bubbles, so we haven't quite got this right yet. We're still working through it. This is sort of our first attempt at trying to dissect some of the topics that are within the data. So the next stage around this is really to get to a place where we've identified the approach that we want to use and we're comfortable with the accuracy of that, so that we can then start to tag that data, come in, help us create some national views, and then work out how we present that information at the location level for our inspectors to understand.
Yes. It all sounds so fantastic. I'm just trying to understand what this is giving you. So, if I've understood, so when people write something which includes the word baby, that means they're probably talking about maternity services.
Probably.
Yeah, okay.
But it's a combination.
I think I could have told you that.
Yeah, of course.
So I'm just wondering what the development of it is. Let's take something that's a little bit less. Sorry, I don't mean to be so. Sorry, but take mental health, for example, where people might the language people use might be not quite directly. It might not be so explicitly linked to the kind of service that they're referring to.
Yeah, and it's it'll be the combination of words together that really help us to differentiate that topic. So even if you took baby out of it, midwife, birth, I think those ones. This was probably quite a polarising topic. It's probably relatively easy to identify, but it'll be the combination of words together that really helps you. Effectively, you cluster those words together or identify what the topic is. So you're right, in mental health, it might be that there are more words and different combinations of those words that might identify that topic. So what it allows us to do, though, so while an inspector might quite easily read one piece of text and identify very quickly what that looks like, what that won't allow us to do is if you can identify over time what those topics look like for a location, and what if we're getting share experience or complaints coming through, actually if over time the number of bits of information related to baby is more than we'd expect for one service compared to another, or maternity, mental health, or whatever it might be, that gives us intelligence that we didn't have previously. So again, we can identify as these pieces come into us from an inspector perspective what that looks like, but our ability to analyse that across time and across services and create benchmarks and things like that is limited today.
Jane.
Just following on from Lewis's comment, I think actually I would encourage you to play with some of this stuff, because it's not all, as Peter said, and it's not all going to work, is it?
No, absolutely.
But this looks interesting, and some of the other earlier things you were talking about were really, really good. I think we should celebrate this. It's very innovative, and it's flexible, and you're trying stuff, and some of it will work and some of it won't. So good luck.
Thank you.
If I may, I think your question's a really good one, Lewis, and I think the significance of this is looking at the data that others hold about health and care, which can get made available to us in a way that our inspectors can sort. So where I'd go with your question on mental health is, let's, for the sake of argument, Healthwatch gets stuff on detention and restraint in a particular unit, then this allows us to look at the way that text is coming at us and understand that, and that then can get converted into evidence that might not otherwise be available to evidence. I can't think of the example now, but we were in a meeting yesterday where the elision between some words and some phrases where actually the same word can mean completely different things in different settings means that the precision of which you set these words becomes important. So I think the skill that's being used here, and that's why I think maternity services is easy. You can say that babies will be involved in every maternity services. But there's other words that we know, just to go back to some of the things where we know maternity services don't work. that you'd want to know as well, probably. So I think the skill of this is building on this base skill about what are the questions you need to interrogate this to begin to convert what is just a bunch of text, basically, into intelligence. So I think the point that this is exciting is absolutely well done, and the organisations that are using this, the skill comes in how you construct the questions you ask to be searched, and then that gives you the data. So this will never replace the experts. As a mental health expert, this is a question I'd like to ask. It's that combination, I think, of experts asking those questions and the machines that come through. But I think that whether we do maternity services or not, I think what's on demonstration here is the skill and the techniques and tools that are available to allow us to actually get a richer understanding. And I think it connects the earlier conversation we're having about how do we take subjective truth and begin to combine that with the statistical evidence, quantitative or qualitative, that we have as well.
And again, if this becomes explicable to the public, like I was saying earlier on about what we're doing, then they can see their subjective truths being part of a wider discussion, rather than us simply saying, that's all very interesting, but what we do is what matters.
And this is how we make that connection.
And you can play back to them the nature of the things they're saying and how that relates to our... It doesn't tell us what to do, but it informs us about what to do, and then the loop needs to go back to them, which says, because you told us this, we came to this.
Yeah, because trying to keep 1,000 stories in your head as an inspector of a service is impossible. This actually means that something becomes more accessible. I'm not sure it makes it more possible, but more accessible.
Yeah, and I think also not forgetting the ability to actually use this for our independent voice. If we can have that national picture, which we'll never get from inspectors using this information day to day as they are already, doesn't allow us to capture that effectively. Okay, the last one on the show and tell is around the local area portal. What we are trying to do with this is to enable staff to work better across sector and to really understand what's going on in their local area. So this is a visualisation example of something we're trying to develop to help better cross-sector working. It's come through the Better Cross-Sector Working Group, and it's really about how do we make information that we have within CQC around the different providers within a location really accessible to everyone who needs to have that information. I'm really excited about this because I think this potentially could be a really important way of creating the bottom-up cross-sector connections that we want to generate amongst our inspectors. We all talk about you need to get out there and find out what's going on in your area, but it's very hard when people have got day jobs and they're really, really busy. Actually, there's some really simple information here that people can get access for themselves and create a pull of that rather than sort of that push, which is perhaps where we have been. So I'll just show you some examples of this. If you, I'd be really, I'm sure the team would be really keen to give you more of an actual real live demo of what this looks like at some point, if that would be useful. I can talk to it, they can talk to it much more exciting and much more enthusiastic way than I can.
So we'll say yes to that, please.
Excellent. Yeah. So we start with the first on slide. What slide are we on? 12. This is just the first view that you would see when you log into this. So this is the map of all of the services that we regulate across the country, and where they have a ratings, they are flagged and colour-coded on this map. So then you can basically drill into different areas that you're interested in. So if you move on to the next slide, you can see what that might look like. So you can either drill down from that high-level map view, or you can do a specific search on a provider or postcode or whatever information it is you want to search on to find the location that you're looking for. You can filter it based on different types of layers. So you can just look at adult social care. You can look at PMS, for instance. You could look by, and you can have different views of the boundaries. So you can have a view around local authority boundaries. You can have a view around CCG boundaries, etc. And when you click on a location, then you get this pop-up box, which basically gives you some information around that location. So it will take you through to the CQC webpage, so the information we hold there. It will give you the rating if you've got it, as you can see on the image there. It will also allow you to link through to Insight, so it will show you, you can go straight through to the Insight product that gives you the information, the more detailed information about the monitoring information we have for that for that location, and also there's also a separate link through to the relationship owner. So say I'm the adult social care inspector in a certain location, and I go on here and I can see that there's some interesting GP practices, or there's some interesting ratings for GP practices around that care home that I look after. You can basically kick in to see who the relationship manager is, who the inspector is for particular GP practices that you're interested in, for instance. I'll give you their contact details, and you can basically get in touch with them and have a conversation about what might be going on that might be impacting the services in that local area. And then it will also help you link through to other locations that particular provider runs as well. So that's where you can get information at the individual location level. And then if you flick onto the next slide, it also allows you to access the area level information that we have for that specific CCG or local authority, for instance, as well. So some of the work that we do that support the local system reviews and the reports that we generated out of that, it will allow you to get access to that information. So I'm quite excited about this. I mean, it's really early days, so I'll say that I think the analysts that built this took about 4 or 5 weeks to do it. A lot of the information's already there. It's about just collating all of that information together. This was presented to the PIP board a couple of weeks ago, and I think some of the comments were a leap of imagination and a methodological game changer. So I think some of the people who are starting to see this are getting really, really excited about what it can do. And really, there isn't new information here. It's just about bringing this information together in a way that makes it really accessible that we've just not been able to do previously. So really, really excited. In terms of where we go with this, so we've been demoing the prototype to various groups. Next quarter, we're going to do a soft launch with a small number of users so that we can really evaluate it, make the tweaks that we need to make, and then we will be ready to go with a big sort of launch to everyone from September onwards. And obviously, we'll continuously improve and iterate that based on user feedback.
Well, I think it's fantastic. And one of the, I mean, I think it's right that the potential is enormous of this. So if I've understood correctly, you're starting now with the potential to show, let's say, all the services within the area of a particular CCG and how they're doing. So that's available. It's the kind of thing that we've talked about even this morning. We were talking about something very similar. But the real prize is that you would, because I think you've talked about it mainly as being something that will help our staff work together with each other.
Yep.
But the real prize is informing the public about the same thing.
Yep.
And not just so that, obviously at the moment you can go on our website and you can see, how good the care homes are where near where you live. But this would create so much more comprehensive information. But the better development of that, thinking of the local system reviews, is that you could imagine the next step would be where you might take maternity services actually, or it could be something else like diabetes care. And instead of just knowing the rating for an organisation as a whole, you would know about the core service ratings, so that if you were a patient who had, let's say, diabetes, or somebody who needed maternity services, you would be able to say, okay, I want to see how good my local provider is, my local maternity unit, or how my acute provider performs on diabetes care, alongside how well my local community services provide. So if you take maternity services, you'd want to know about your maternity unit, you'd want to know about your health visitors, you might want to know about your GP, and all of that would be part of how you picture your care. If you want to take diabetes, you'd want to know about whether the community district nurse, or let's say the community diabetes service, but the podiatrist and all the other people who might be involved, the ability to pick up the pathway of your care for your specific condition through this kind of model is fantastic. But I would say that is the real prize. That's I know that's the next stage. Yeah. But if they can do this in 4 or 5 weeks, just add another couple, another couple of weeks, and you can do the rest as well.
Okay. Well, this is a game changer. This is a really exciting bit of work. And I just support what Lewis is saying. I mean, a public-facing version of this would be really very exciting, and I think it would be highly appreciated by the public, who, I think have difficulty accessing our reports through our current website. But accessing it through this graphical interface based on geographical areas, I think would be very interesting. But for us internally, it would be very interesting. I think one of the key things that is going to be important about this is accessibility. I mean, this is something we need our teams and the public to be able to access fairly easily and not jump through lots of technical hoops to get into.
Yeah.
So can we just think about how easily people could access it? Because if you can access it from any PC attached to the internet, that would make a big difference both to the public but also to our staff as well, rather than through some network protocol that makes it much more difficult to access.
Yeah, currently it's the sort of the first layer that you see is accessible, but to click into Insight or to click in to get the information about the relationship manager in Insight, that's all through CRM. So absolutely, those are things that we need to develop over time.
And presumably there are layers. You could make a lot of it accessible to the public, but also have some of it only accessible to employees when it's information only really for our internal staff.
Yeah, absolutely.
But all this information's public. So we're only recollating public information. So therefore, the whole thing's public.
So
not perhaps the relationship manager, but who cares, right? But actually, the ability to drill down into a diabetes pathway, it's only we're reorganising existing information that we've given to the public.
So I think there are parts of CQC Insight which we are on. I think I'm right in saying some of it isn't public. So some pieces I think may need to not be, but. Our view is to be as transparent and open with all of this as possible. So as much as we can make this available to the public, we absolutely should.
And just building on Ted's point for accessibility, then the language that you use and the designations will need to be public friendly.
Absolutely.
And maybe our colleagues in Healthwatch can help you out with that.
Yeah, I think the approach with all of our products going forward is that we really involve the users, the end user, in the development of those. So as we go forward to creating potential public version of this, we'd absolutely need to involve the right user groups to make sure we were making it as accessible as possible in that way.
Helen, can I just ask you, some of this stuff is really good, suitable for making into apps, and obviously that's probably not our remit. But how are we once we've got it? Are we thinking about engaging wider with people like app developers to actually being able to get this information out there into a really user-friendly way, which is without us having to do it, but really sort of engage in that space?
Yeah, I mean, it's not something we've actively been sort of pursuing at this point. I think we've had a lot of conversations. So there's a relatively new head of architecture within the digital team. There's new digital heads of sort of coming through now as part of that restructure. So I think this is all part of how are we making all of our information as accessible as possible in the future. Absolutely, we should be thinking about that.
Anything else? So, Helen, I think this has been a story of good news and bad news. So the good news is everybody's really, really excited by everything you've said. The bad news is that we want more of it within a few days, if not weeks. Seriously, I think this is very, very encouraging, and you've been brilliant over the last year or so since you've been with us in getting the foundations in place patiently for this to happen. So on behalf of the board, thank you, but would you also pass our thanks on to your team, because this is clearly a lot of people doing some very clever and potentially very, very valuable stuff. So thank you.
I absolutely will do. Thank you.
Good. Right. So talking of good people doing good things, I think that takes us on to the recognising outstanding contribution award, and I think have I missed something out? No, that's all right. I thought I was being told I'd made no. Good, right. So what I was going to say was, one of the good things about my role is meeting a lot of our people who do fantastic things. And one of the disappointments is that I don't actually get to meet everybody that's doing fantastic things around the patch. But having the Rock Awards and having the winner comes here at least gives all of us a chance to meet some of those people. So I'm going to read out what Richard McGee, who's got this award, what the citation says, because if I try and paraphrase it, I will just not do it justice. So forgive me if I just read this out. So So Richard works in the information sharing team that deals with all of the hard copy information that is sent to NCSC. And this includes roughly 1,900 notifications each day, local authority concerns, outcomes, meeting minutes, and so on, which are another sort of 200 a day. So you get a picture of a large volume of hard copy information. So Richard was nominated for the Rock Award following his identification of a number of issues which he believes should be reviewed to make the process more efficient and lean. So something that we talk a lot about, how do we get more efficient? And the idea was then, or his idea I should say, was then taken forward by developers who, as a result of his creative thinking, took his idea a step further, and as a result, CRM now, with a click of a button, auto-renames attachments within inquiries. And this has not only benefited Richard's team, but those who process information within NCSC, and also anyone within CQC who's required to rename documents received within an inquiry. Now, you may not get, even now, quite the picture of the sort of volume of what this is all about, but Richard's team alone processes around 26,000 inquiries a year, which equates to a minimum of 52,000 times of opening, renaming and closing documents. So you get a picture that Richard's suggestion, based on his knowledge of what he was doing day to day, has now come up with a recommendation for improvement that has had phenomenal impact. So I think it's just really great. I'm sure you'd all join with me in congratulating Richard. I should also say one of the other great advantages of being chairman is from time to time I get to be Kirsty's sidekick or bad carrier or anything else. So I have, Richard, an award to actually hand you, although I see that it's signed very nicely by Kirsty, not by me. So Richard, come and...
Did you get it?
wait a minute. Yeah. Can we sort of do a proper photo, shake hands, and hold that thing, and do all of that? Got it? Perfect. We'll sort you in a minute. Thank you, Richard. No, thank you. Fantastic. Great. So, board, is there any other business? Yes, Malta.
While we're on congratulations, I just wanted to mention that our Director of Policies and Strategies' baby daughter was born this morning while we were meeting as a board. No correlation, everyone is well and healthy, and I thought we all congratulate her for the birth of her daughter.
So her strategy, she hasn't lost her touch on the strategy, coincide with the board meeting, fantastic.
So what kind of baby?
Important piece of information.
Yeah, so following Lewis's tradition, it's not just baby you need, it's We're going to script the website, Paul.
So no doubt, even in this minute, she'll be watching the live, or at least not live, but she'll be watching the board as it goes up. And so very many congratulations to her. Thanks for the update. Good. Any other business from anybody? So I said we were not going to have time for questions from the public, but if there is anything, we haven't been notified about anything, but if anybody wants to raise anything, we'll have time for David. One question. Although I thought between Andrew and I we actually answered your question, but anyway, perhaps you've got another one.
Sorry. David Hogarth, Neighbour Care, St John's Wood and Maida Vale. We are a befriending organisation in North London. We were having a meeting in April, and one of our befrienders reported that the person she was befriending was going into a home in what used to be the Triborough area. It was a home, in fact, which I'd visited an interim view visit for Healthwatch a long time ago. I hadn't been very happy with it, and none of us, in fact, have been very happy with it, so I was alarmed. I went, therefore, I said I'd go to the CQC website, and I did go to the CQC, and the very first thing I saw was that a whistleblower had reported that this home had recently been getting up people at 4 or 5 in the morning in order that the night staff could do it and not the day staff. And I passed this on to the befriender, passed it on to the person's son, and as a result of this, the person is not going into that home at all. She's staying in a place she likes where she's receiving respite care, but they also have a long stay facility. And everybody so far anyway is very happy about this. And I'm telling you this story for 2 reasons. First of all, I would like to thank the CQC for 2 reasons. First of all, for putting this on the website, putting it into the report and being transparent about it, because in the past they might just have said that we had concerns, and that wouldn't really have been enough. And secondly, the CQC went in. This was one of the 6% of whistleblowing reports that actually brings forward planned action, and they went in at 6:20 in the morning and now discovered they didn't discover anything. They discovered everything was well. Nonetheless, I didn't entirely trust that, nor did the Sun nor anybody else. We thought probably the whistleblower was telling the truth, and that's why we had the outcome we did. So I'd like to say that that's one thing I'd like to thank the CQC for that. But also, I think the fact that you didn't find it when you went in, I think does highlight the thing which I keep saying, and I have the same worry about saying the same thing twice as Lewis has had, is that is that you weren't able to discover that this was happening. I'm pretty sure that it was happening. And I'm hoping, when I get my head more round intelligence, that perhaps intelligence will help with this. But also, of course, my own thing is cameras, and particularly two-way audio cameras where you can communicate with the resident as well as surveying or monitoring what goes on. That if those cameras had been there, and if the CQC had known that those cameras were there, you would probably not have had to go there at 6:20 in the morning at all. You could just have had a look and seen if this was general practice or not. So I keep saying the same thing. I'm just hoping that somewhere you will think of other ways than inspection to find out the truth about what is going on in these places. So it's a bit of a mixed bag.
So thank you, David. I mean, I think a lot of what you said plays in really well to the conversation that we've just had with Helen, and comments that various board colleagues have made about the importance of not only getting intelligence but making that as available as possible to the public. So I think that's great. And on your point about cameras and other devices, we've already said we're having a report back in the July board. So noted, and we'll see where that takes us. So thank you very much indeed. And with that, ladies and gentlemen, we bring the meeting to an end. Thank you very much indeed.